Bismillahirrahmanirrahim. Today my topic of presentation is screening of disease. No act of kindness, no matter how much small, is ever wasted. Learning objectives of today's presentation is introduction of screening, types of screening, criteria for screening, sensitivity, specificity, negative predictive value, positive predictive value, reliability, recent advances and MCQs. By the end of this presentation, participant will be able to describe the introduction of screening, types of screening, criteria for screening, sensitivity, specificity, negative predictive value, positive predictive value, and reliability. Introduction. Biggest challenge in preventive medicine is to distinguish between people who have the disease and those who don't have disease. As we see in iceberg phenomena, it gives an idea about progress of disease from its subclinical stage to about disease, and there is submerged portion which is consist large portion is submerged, which includes subclinical cases, carriers, undiagnosed case, and at the tip there is clinical disease. The search for unrecognized disease or defect by means of rapidly blood test, examination, or other procedure in apparently healthy individual. Earlier, it was to conserve physician time for diagnosis, administer an inexpensive lab test, but today screening is considered a form of secondary prevention, and it detects disease in its early asymptomatic phase, whereby early treatment can be given and disease can be cured and its progression can be delayed. Prevention and natural history of disease. This is natural history of disease is biological onset of disease, then there is preclinical phase, then symptoms appear, clinical phase, and therapy begins, and then outcome, disability, death, or recovery. In the screening, as we know, the primary prevention is promoting health, which is given before biological onset of disease. The screening is actually the secondary prevention, and we can, if we detect early the disease before the symptoms appear, then we can decrease the progression of disease. Therefore, screening can results in potential improvement by screening before the symptoms of disease and before the clinical phase become more severe. Therefore, this gives the advantage of lead time, which is actually the time. This is a biological onset disease, then disease detection by screening, and symptoms and diagnosis. If we can detect the disease before the onset of symptoms, then by rapid blood test, then there is a period between diagnosis by early detection and diagnosis by other means. This is the advantage gained by screening, and this is known as lead time, which is detected by screening. And the screening program works better when there is time lag between the disease onset and its final critical point are sufficiently long. There is difference between screening tests and diagnostic tests. Screening tests performed on apparently healthy individuals, and it is performed on sick or ill individual. It applied to groups, whereas diagnostic on single patient, it results are arbitrary and final, whereas in this diagnosis is not final. It is based on one criteria and cutoff, but diagnostic test based on evaluation of number of signs and symptoms and lab finding. Screening test is less accurate and less expensive. It is more accurate and more expensive. Screening test is not basis for treatment. Diagnosis test is used as a basis for treatment. In screening test, initiative comes from investigator, whereas in diagnostic test, initiative comes from patient. Uses of screening test. Screening test is also used for case detection, which is known as prescriptive screening, which is a presumptive identification of unrecognized disease which does not arise from patient request. For example, neonatal screening, the people are screened primarily for their own benefit. For example, here pick blood sample. Control of disease, which is known as prospective screening. People are examined for benefits of other. Screening of immigrants from infectious disease like Ebola, TB, and syphilis to protect the home population. Screening from HIV or STDs. Screening programs may also, by leading to early diagnosis, permit more effective treatment, reduce the spread of infectious disease and mortality. Research purpose to know the natural history of disease of many chronic disease like cancer or hypertension. Screening may aid in obtaining more basic knowledge about natural history of such disease. Initial screening provides a prevalence estimate and subsequent screening provides an incidence figure. It can also be used for educational opportunities. For example, screening program help in acquisition of information of public health relevance, provides opportunities for creating public awareness for educating health professionals. Types of screening. Mass screening. It is actually application of screening test to a large unselected population. Everyone in the group is screened regardless of probability of having the disease or condition. For example, visual defect in all school children, mammography in women, colonoscopy for occult blood. There is also the screening which is high risk selective or targeted screening. In this, there's a screening of selected high risk groups in population. Screening fetus for Down syndrome in mother who already have a baby with Down syndrome. Screening for familial cancer, hypertension and diabetes. Screening for CS cervix in low socioeconomic status women and screening from HIV in high risk group. Multi-purpose screening, the screening of population by more than one test done simultaneous to detect more than one disease. Screening of pregnant women for a VDRL, HIV, A, hepatitis B by serological test. Multi-phase screening, the screening in which various diagnostic procedures are employed during the same screening program. For example, in diabetes, fasting blood glucose or glucose tolerance test, sickle cell anemia, CBC or hemoglobin electrophoresis. Criteria for screening. Before initiating a screening program, a decision must be made whether it abides to all ethical, scientific, and financial justification or not. The principle that would govern the introduction of screening program first enunciated by Wilson and Janker in 1968. The criteria of screening based on two consideration: disease or screening test. The disease should be important public health problem, should be highly prevalent. Disease should have long and detectable preclinical stage. Natural history of the disease should be adequately understood. Appropriate tests must be available for early detection of disease. Facilities must be available for diagnosis of disease. For example, confirmation of gold standard. Early detection of disease and treatment should be able to reduce mortality and morbidity. The disease should be treatable and there should be recognized treatment for lesion identified following screening. Expected benefit must exceed risk and cost. A policy should be agreed on concerning whom to treat as a patient. Screening tests should be inexpensive and easy to apply, acceptable, valid, reliable, or high yield. Simplicity, the test should be simple to perform, easy to interpret, and where possible capable of use by paramedic or other personnel. For example, blood and urine test and ECG for early detection of hypertension. Acceptability, since participation in screening is voluntary and tests must be acceptable to those undergoing it. In general, tests are in general tests that are painful, discomforting, embarrassing, and not likely to be acceptable. Validity and reliability. What is the validity? Validity is actually the accuracy of test. Reliability is the precision of test. Accuracy is how close is the result of the test to its true value, whereas precision is how close are the result of test on repetition. Validity determines the accuracy of test. It expresses the ability of test to separate those who have the disease from those who don't have the disease. A test with little systematic error is valid test. Components of validity: sensitivity, specificity, or predictive accuracy. Sensitivity. Sensitivity is the ability of the test to correctly identify those who have the disease or true positive or proportion of truly ill population. This is 2 by 2 table. On this, there is gold standard, which diagnose disease is present and absent. Then there is results of the test positive and test negative. On the basis of disease, when the disease is present and it is also positive on test, then it is known as true positive. When the disease is absent and the test is positive, then this is false positive. And in false negative is those who have the disease is present but test is negative. And true negative, disease is absent and test is also negative. And true negative is specificity. The specificity is actually the ability of test to correctly identify those who don't have the disease or true negative proportion of truly healthy population. This is specificity, true negative divided by true negative plus false positive. Calculating the screen sensitivity. For example, in a practice population, there is disease and known disease, and the screening test is positive or negative. If we calculate the screening test sensitivity of test, then 82 positive divided by 100, 80% is sensitivity, and specificity is the true negative 800 divided by total 989%. Therefore, an ideal screening test should have 100% sensitivity and 100% specificity, but ideally this practically is impossible. False negative. If a person with disease is labeled negative, then there may be false reassurance and ignores any disease sign and symptoms, and there may be postponement of treatment and detrimental to overall health. And therefore, there is low sensitivity and high specificity. False positive. If a person without disease is labeled positive, further testing with long, expensive test discomfort, inconvenience, and anxiety, increased burden on health facilities, emotional trauma, difficulty in delabeling. Therefore, there is high sensitivity and low specificity. Thus, a screening test result may be bimodal, there is value is positive or negative, or it may be unimodal, of result value or unimodal. That's why this come like a concept of cutoff point is also in screening, such as unlike in bimodal distribution, which is dichotomous, yes or no. Some disease come in continuous variable, for example, diabetes or hypertension is quantitative. In these cases, it is difficult to calculate sensitivity and specificity. Therefore, a concept of cutoff must be set to distinguish between positive and negative result in continuous variable. For example, consider in this graph, there is 20 diabetic and 20 non-diabetic screen use a blood sugar level vertical axis from low to high. This is low value and this is high, and this is blood sugar test, and this is 20 diabetic and 20 non-diabetic. When we set a low cutoff value, then when we set the low cutoff value or distinguish between diabetic and non-diabetic, then the sensitivity become the 85% and specificity become 80-20%, means sensitivity increase and false positive originates. More non-diabetics are diagnosed positively if low cutoff point set. If we set high cutoff point, then there is sensitivity decrease and specificity increase. Specificity increase. Therefore, false negative originate more. More diabetics are not diagnosed positively. Therefore, this may be a problem. So, different cutoff yield different sensitivity and specificity. The cutoff point that identify more true negative will also identify more false negative. The cutoff point that identify more true positive will also identify more false positive. Therefore, the choice of high or low cutoff level for screening therefore depends on the importance we attach to false positive or false negative. Therefore, for this in case of lethal disease, early intervention possible, cutoff point must be set at low level as greater sensitivity is required. False positive can be tolerated. Multiple tests. There may be sequential testing, which is two-stage, which include after the first screening test is conducted, those who test positive are brought back for second test to further reduce false positive. Consequently, the overall process will increase specificity but with reduced sensitivity. Net sensitivity and net specificity can be calculated from both tests in sequence. Net sensitivity falls, but net specificity will be gained in sequential testing. In simultaneous testing, two or more tests are conducted in parallel. The goal is to maximize the probability that subjects with disease true positives are identified, high sensitivity. Consequently, more false positives are also identified, specificity low. In simultaneous testing, net sensitivity is gained, but net specificity will be lost when compared to either type of test. Therefore, in screening, there is sensitivity plays a most important role as compared to specificity. Now come the predictive accuracy. There is two type of predictive value. One is positive predictive value, other is negative predictive value. Positive predictive value is the proportion of people who screen positive that actually have the disease. Negative predictive value is the proportion of the people who screen negative that are actually free of disease. Are the people without disease correctly identified? These values are not fixated for a particular test. For example, positive predictive value 80 divided by 180 divided by 180, it is 44%. And if we calculate negative predictive value to negative 800 divided by total 820, then it is give the 98% negative predictive value. Predictive accuracy actually depends on the prevalence of disease and specificity of test. More prevalent disease has high positive predictive value. That is why screening is more efficient and productive if done in high-risk population. Increase in sensitivity causes a modest increase in positive predictive value, but an increase in specificity raises positive predictive value markedly. Reliability. Reliability determines the precision of test. Reliability is actually repeatability. It means that all the results of test should be similar cluster at one place when conducted each and every time. This is not possible because the variation that cause the test to not yield same result every time, like lab equipment failure. There are three types of variation: intra-subject variation, intra-observer variation, intra-observer variation, or inter-observer variation. Intra-subject variation include this is variation in which the result of the test conducted over time, short period on the same individual. The difference is due to changes that occur to the individual over the that time period. For example, blood pressure in female, male, and male, there is changes in basal blood pressure, lowest or highest or causal variation in BP during 24-hour period, which is actually the change in the individual itself, which is known as intra-subject variation. There is intra-observer variation. This is a variation in the result of test due to same observer examining the result at different times. For example, two readings of blood pressure by the same observer. Inter-observer variation is the variation in the result of test due to multiple observers examining the result. For example, chest X-ray read by the two different radiologists. This is the bell-shaped curve. Test result valid but not reliable. Test result valid and reliable both. This is true value when it is deviate, then test results are reliable but not valid. Yield. Yield is the amount of previously unrecognized disease that is detected and brought to treatment as a result of screening. Yield is true positive plus false positive divided by true positive plus false positive, true negative plus false negative. It depends on the prevalence of disease and sensitivity on of the screening test participation in the program. Hence, yield of screening test is high in high risk screening. Evaluation of screening programs. Screening programs can be evaluated by experimental conduct on RCT of the screening test to compare the disease-specific cumulative mortality rate between intervention and control group. The problems include long follow-up, post and record keeping. Non-experimental include we can study conduct cohort study, case control study, ecological study, which is correlation of screening for pattern and disease experience of several population. Most popular screening tests, for example, mammography has sensitivity 75 to 95%, specificity 83 to 98%. PAP test have the 29 to 56% sensitivity, specificity 94 to 100%. PSA test for prostate cancer has sensitivity 20 to 32% and specificity 94 to 97%. FPS fasting blood sugar sensitivity 85 to 89%, specificity 70 to 77%. Rapid ELISA has sensitivity 99.5%, specificity 98%. Conclusion. Screening, despite its flaws, is a major public health determinant measured by its effect on mortality, morbidity, and disability. Establishing appropriate criteria requires considerable knowledge of natural history of disease and adequate facility of follow-up and treatment. It is necessary to ensure that program is continuously monitored to confirm that effectiveness is maintained when if it exceeds the costs. Newer fields such as genetic screening are on the rise, would help us, which would help the cause. Now, recent advances. The role of imaging in screening special feature commentary. There is surveillance and screening principle and practice article is published. That health screening can also be applied to population, not individuals. For it to be effective, the initial screening test must be acceptable and reasonably accurate. The disease must be treatable with better outcome when treated early, and harm and cost associated with screening must not outweigh its benefit. Robust evidence is therefore required before systematic screening is implemented, whereas surveillance implies the testing of people at high risk of disease and is therefore distinct from screening in both scale smaller and intensity greater. In both cases, however, clear information must be provided to potential participants so that they can weigh up the balance of benefit and harm before deciding on whether or not to engage the process. Another article published which assessed the value of screening tools, reviewing the challenges and opportunities of cost-effective analysis. In this background, screening is an important part of preventive medicine. Ideally, screening tools identify patient early enough to provide treatment and avoid or reduce symptom and other consequences, improving health outcomes of the population at reasonable cost. Cost effectiveness analysis combines the expected benefit and cost of benefit. This review seeks to evaluate the latest cost effective analysis on screening tools. It is actually a systematic literature which is set on Medline and was published on screening tools in 2017. Four key categories were identified: screening pathways, pre-symptomatic disease, treatment outcomes, and known health benefits. Not all studies included treatment outcome. 15 studies did not include treatment following diagnosis. Quality tested live years were used by 35 as the main outcome. Studies that undertook a societal perspective did not report known health benefit and cost consistently. Two important challenges were identified: estimating the sojourn's time, which is the time between when a patient can be identified by screening test and when they would have been identified due to symptoms, and estimating the treatment effect and progression rates of patients identified early. Therefore, according to Puyan, to capture all important cost and outcome of screening tools, screening pathway should be modeled, including patient treatment. Also, false positive and false negative patients are likely to have important costs and consequences and should be included in analysis. As these patients are difficult to identify in regular data sources, common treatment patterns should be used to determine how these patients are likely to be treated. It is important that assumptions are clearly indicated and that the consequences of these assumptions are tested in sensitivity analysis, particularly the assumption of independence of objective testing. Another article published is approach to nutritional screening in patients with COVID-19. Malnutrition, as we know, is common among severe patients with COVID-19, mainly elderly adults and patients with comorbidities. Therefore, this is a crucial important the urgency and rapid progression of disease in vulnerable group. This review examined the available literature for different nutritional screening approaches implemented during COVID-19 with a special focus on elderly adults. Literature showed that scrutinized 14 studies assessing malnutrition among COVID-19 nutritional risk screening to 2002 has demonstrated superior sensitivity to other traditional screening measures. The controlling nutritional status CONUT score, which compromises of serum albumin level, cholesterol level, and lymphocyte count, as well as combined CONUT lactate dehydrogenase C-reactive protein score, expressed a predictive capacity even superior to that of NRS 202 in middle and elder COVID-19. Therefore, simple measure based on routinely conducted laboratory investigations such as CONUT score may be timely, cheap, and valuable alternative for identifying COVID-19 patients with high nutritional risk. Therefore, mini nutritional assessment was the only measure used to detect residual malnutrition and high malnutrition risk in remitting patients. Therefore, older patient males with severe inflammation, GIT symptom, pre-existing comorbidities are more prone to malnutrition and subsequent poor COVID-19 prognosis both during acute phase and during convalescent phase. And therefore, they are in need of frequent nutritional monitoring. Now, time for MCQs. MCQs 1. Screening patient for preclinical diseases established part of day-to-day medical practice. Screening test specificity is ability of test to correctly identify A false positive, B false true positive, C true negative, D false negative.
D.
C.
C. C is the correct answer. Specificity is actually ability of the test to correctly identify those who don't have disease. And C is the correct answer, true negatives. Result of the screening test for diabetes compared to confirmatory test oral glucose tolerance test is given. On diagnosis, there is diabetic and non-diabetic, and the sensitive test result is positive and negative. This is 2 by 2 table, and what will be the specificity of the test? A is 96.1%, B is 86.2%, C 76.1%, D 56.1%, E 66.1%.
A.
Alpha. Yes, as we know that sense specificity is calculated by true negative 500 divided by 520, and if we calculate then 96.1% of alpha is the correct answer. MCQ 3. A comparison of clinically diagnosed versus autopsy confirmed gastric and peptic ulcer was performed on 750 consecutive disease patients in several large hospitals shows in following table. From these data, the sensitivity of clinical diagnosis, this is autopsy finding, ulcer patient and non-ulcer patient, clinical diagnosis, ulcer or non-ulcer, and total. What will be the sensitivity in this case? Alpha 100 by 200, beta 150 by 200, C 250 by 300, delta 100 by 250, and E 150 by 250.
D.
Delta.
Delta will be correct answer. Sensitivity is 2 positive divided by total. 100 divided by 250 will be correct answer. Delta is correct option. MCQs 4. Which of the following characteristic is not of much importance in a screening test? Alpha low cost, B high safety margin, C high sensitivity, delta high specificity.
C.
D.
Yes, delta is correct answer. As in a screening test, we all know that the test should be low cost, high safety margin, and highly sensitive. But it may be specific, but specificity is not a major criterion in screening. Therefore, delta is the correct option. It is not much important in screening test. MCQs 5. Results of screening test for hypertension in the ABC community. The sensitivity of test is diagnosis, hypertension, non-hypertension, the test result positive, negative, and total. What will be the sensitivity of the test in this case? Beta will be the correct option, 33.3%. Add 100 divided by 300, then 33.3%. Beta will be the correct sensitivity of the test is 33.3%. MCQ 6. 5 lateral radiograph patients with single level cervical degenerative disc were selected and measured on 2 separate occasions by 3 spine surgeons using 3 different measurement techniques. Cervical sagittal rotation was measured using 3 different techniques which showed different results from 3 surgeons. The type of variation in this scenario is alpha intra-subject variation, beta inter-subject variation, C intra-observer variation, and D inter-observer variation.
Delta.
Delta will be correct option. As in this scenario, you see that the two separate occasions by 3 spinal surgeon estimated the lateral radiograph of patient on 3 different techniques and give different results from 3 surgeons. Therefore, it is the inter-observer variation. Delta will be the correct option. Results of screening test for prostate cancer in XYZ community is given. Diagnosis prostate CA and non-prostate CA, and on test is positive, negative. 2 by 2 table, what will be the positive predictive value of the test? Alpha 41.6%, beta 31.6%, C 21.6%, D 11.6%, E 61.6%.
Alpha.
Yes, alpha, it will be the correct answer. 250 by 250 by 600, then it gives 41.6%. Alpha will be the correct answer. MCQ said Mr. Akbar reviewed Mr. Akbar reviewed the patient on 2 separate occasions. On the first occasion, he documented no finding in chest X-ray. The next day, he found pulmonary opacity in 6 out of 10 chest X-ray radiograph for COVID-19 patient. The type of variation in this scenario is alpha intra-subject variation, beta inter-subject variation, C intra-observer variation, D inter-observer variation.
C.
C is correct option because it is the same observer and on different occasion he documented the different reading. Therefore, it will be the intra-observer variation. C will be the correct option. Other option is not true. The result of screening test in ABC community is given in breast CA. The negative predictive value of this is the given diagnosis breast CA and non-breast carcinoma. and on the test there is positive negative results, what will be the negative predictive value of the test?
C.
Yes, C will be the correct answer. Negative predictive value 200 divided by 350. It gives the 0.57 when you multiply by 157.1%. C will be the correct option. 57.1%. All correct option are false, so 57.1% will be the correct option. Hypertension is the highly prevalent in the health department starting is highly prevalent XYZ community. Health department started a screening program for hypertension in this community, and hypertension screening program is more productive and efficient when performed on high risk population because the more prevalent disease have alpha high positive predictive value, beta low positive predictive value, C high negative predictive value, delta low negative predictive value, E low sensitivity. What will be the correct option?
A.
Yes, alpha will be the correct option as I have already mentioned in my presentation that the if the disease is prevalent and screening is performed on high risk population, and to be a screening program more productive and efficient, it should be performed on high risk population. Therefore thus therefore the screening should be more productive, and therefore the prevalent because the more prevalent disease has high positive predictive value. Therefore, the correct option is alpha, as the more prevalent disease has high positive predictive value, and the screening program become more productive and efficient if performed on high-risk population, which is known as selective screening, type of selective screening. Therefore, alpha will be the correct option. This is the key of my MCQs, references. Thank you.
Okay, thank you very much, Dr. Khansa. Very nice presentation. This is excellent how you have presented, and the MCQs, they again referring back to the presentation and the important concepts that have been given. So this screening is very important, as I have already told you that we have some of the national and provincial screening programs, but we are still looking forward to having more screening programs. Especially we are working on cervical cancer and other important things like this in our provincial as well as in national policy. So screening is one of the most important topic whenever the health policy is concerned. I was looking towards the national screening programs, and still there is lot of gaps that has to be filled, and these gaps cannot be filled until and unless our people from community medicine, they take a lead, they come forward and they contribute into this national cause. No health system, no health policy can work just on tertiary care. The load on tertiary care can only be prevented if the proper screening is done among the healthy population at the right time with the right test and with the right cost. The most high sensitivity and that we have to take care of. Again, a very good presentation. In the references, I must say that the reference from the textbook of community medicine and public health, edited by myself and Sabina Jalal, should also be added because a very nicely written chapter is present on screening as well as on public health policy and systems. So all those presenters who are coming in a few days, please take important points. It is allowed by the editors, it is allowed by the authors. Do take the points from the important books, journals, and written material, but do give the reference. And preferably, the reference should be in the footnote on the slide where the important points are being presented rather than on the last slide. These are my few suggestions to improve further. Very well done, Dr. Khansa, and looking forward for the next presentation tomorrow, inshallah. Allah Hafiz, stay blessed. Once more, Allah bless you all.